Please join me in offering a warm welcome to Dr. Doug Eby, Executive Vice President of Specialty Services at South Central Foundation, and longtime IHI faculty member, trusted collaborator, and valued leader within the IHI Leadership Alliance.
We obviously brought way too many people to this forum. 35 years ago, Don Berwick made an almost 5,000-mile trip to Anchorage, Alaska, 35 years ago. And I happened to be in the room of a few of us learned about Edward Deming, the red bead game, and continuous quality improvement, and became part of the not-so-exclusive club of Don's best friends, numbering now 1,000 or 2,000 people. This ability to deeply focus on the person in front of him, to be endlessly curious and to show genuine caring makes him a truly very special and impactful person. I am Doug Eby, physician executive privileged to work for 35 years in support of Alaska Native people as they have reinvented healthcare from a community-driven design perspective. The visit of Don to Alaska changed the course of my life and the course of the Alaska Native Medical Center and lit the flames for what eventually became a two-time National Baldrige Award-winning SCF NUCA system of care. Don believed in us and coached us and encouraged us for these 35 years nonstop, connected us with others, made me and us feel always valued, and then literally shared our story around the entire world. Our story and my personal journey, though, are not unique in the Don Berwick universe. It almost doesn't matter where you are. A rural clinic, a national ministry, a conference room halfway around the world, and someone will know Don, someone will quote Don, and someone will tell you how his work and his personal interest and ability to connect people has changed the way they deliver healthcare. There are only a handful of people in healthcare whose influence truly spans the globe, and Don Berwick is one of them. That kind of reach comes from a lifetime of creativity and courage, and from Don's unwavering belief that harm and inequity are design problems, not destiny. He teaches us that improvement is far more important than a set of methods. It's a way of understanding systems through the lens of human experience so that we can see and remove what gets in the way of excellence. Today, he still calls us to bridge the gap between what we have and what we aspire to. And when it comes time at the National Forum for the Berwick plenary, people sit up a little straighter, they put their cell phones down, and they have a shared sense that what we're about to hear is something that will challenge us, will inspire us, and will stay with us long after the forum ends. It's a huge honor to welcome to this podium an incredible inspiration, a truly, deeply genuine person, the truly incomparable Don Berwick.
Thank you so much, Doug, for lowering expectations. No, really, in this wonderful community of people who really want to make change, I have no friend or colleague more valued than Doug Eby. Doug's contributions to this effort globally have been peerless. Doug would be the first to say he's successful because he works in and for an Alaska Native community and leaders at South Central Foundation that, along with Doug, have now placed South Central, I think, maybe first in the world in terms of organizations worth studying to understand what the future should look like. So, Doug, thank you so much. While I've got that theme, I want to also say a word about my colleague, Pierre Barker, who has been the intellectual leader, really, of IHI now for a long time. Like Doug, Pierre is heading for retirement now. Doug will be stepping down from his role at South Central, becoming IHI Senior Fellows, and even hopefully closer to the work we do. I don't know if you're in the room, Pierre, but thank you so much for your. Why don't you stand up and take it. While we're doing thank yous, I want to publicly thank Sylvia Trent Adams, our new CEO, for taking the reins. If you study her track record, where she's been, what she's done, she's going to bring a whole new range of connections and wisdom and experiences and networks to the mission here. We're very, very fortunate to have a leader of that stature join us, and I look forward to helping her succeed in every way I possibly can. And one final thank you, which is going to drown out the place with noise, but it's the blue shirts, the people on the staff who really make this possible. I cannot get over what they do minute by minute through this event and through the year to help our organization thrive. I've got a couple of warnings before I start my more formal talk. One is I usually, talks I give at the forum are always the first time I've given them. That's not true here. Some of you have heard this because I've been around the country really telling more or less the same story. Those of you who heard it before have my permission to get up and leave. But I will keep talking until the last person is left. You're also going to hear some repetition. What I'm going to do in the time I have is to talk about our journey to this moment in the improvement movement. At my age, I start to reflect on kind of history a lot. And I want to tell you my current view of the evolution of the enterprise of improvement as I've experienced it in healthcare. Through really now nearly 40 years. There's a journey underway here, and I want to describe how I see that journey. So it's a trip through time. Because of that, I'm going to be going back and recovering some slides and stuff from prior talks, because you're going to see this evolve until I get to what I think is kind of the newest stage we're in. Also, just in case I forget to make the point, I'm not saying the past is left behind. It isn't. We built upon the past, and so everything we started is still here, alive, well, and needs to be nurtured as well. Where we started, I call phase one, which was project-by-project improvement. It actually was Dr. Joseph Duran who said and wrote, improvement occurs project by project and in no other way. Now, I certainly am at great risk to disagree with Dr. Duran about anything. He was an absolutely brilliant man. And in some ways, he's right. It's always going to come down to ground, and something happens, and then we carry out a task. And that's the way I thought about improvement when IHI was founded. If you look at our history, it was a series of problems identified and then throwing what we had at the problem using these amazing tools of improvement taught by people like Bob Lloyd and others who really were students of systems and statistics and knew how to make things different. All of that was given a tremendous shape in 1999 and 2001 when the National Academy of Medicine, a very conservative body, really went out on a limb and said, boy, are we screwing up. I don't think that's the term they used. But they said we really have to improve because we're not meeting social needs. The sentence that it said was, in its form, habits, and capacities, the healthcare system's incapable of meeting the needs of the communities we're supposed to serve. I had the privilege of helping to write these two reports, To Err is Human and Crossing the Quality Chasm, and very significantly, the Chasm report, as all of you know, I'm sure, in 2001 laid out a list of targets for projects, basically. Things that should be better. That list you see here became canonical. Safety, don't harm people. Effectiveness, use science to help people. Patient-centeredness, work on what matters to them, as Maureen has taught us. We didn't have Maureen's language at that time, but now we do. Timeliness, that delay is usually, unless it's instrumental, is waste, and so we need to understand flow. Efficiency is reduction of waste in all forms. And equity, which I think if this report were being written now would probably be at the top of the list, given what we now know scientifically, is closing racial and socioeconomic gaps. And so we began to work on it. Safe, effective, patient-centered, timely, efficient, equitable care. That was the name of our movement, the platform of work, probably through most of the 1990s anyway. The successes accumulated. This is way back to, I don't remember the date of this, but this is Rick Shannon's work at West Penn Allegheny Hospital back in the day, where Rick, an intensive care doctor, began to think that central line infections, bacteremias from indwelling catheters, were not inevitable. When I was in training, I trained in internal medicine before peds, we were taught, as the bumper sticker sort of says, stuff happens. That's not what the bumper sticker says, but I don't want to. It's like, you're gonna have infections if you put lines in people. I don't know the rate, but it'd be 10, 12%. No one was surprised, and the patients were put at great risk. Rick said, no, I bet there's a way to harness knowledge with the help of the Society for Critical Care Medicine and the infectious disease community. And he came up with what eventually became known as the central line bundle, which is a set of very disciplined procedures when you put in an indwelling catheter, a central line catheter, which eliminated central line infections. Rick got almost to zero and published it, showed us, and others followed. Stunning project result. I'm sure cumulatively through the years since that work began, we're talking about certainly tens of thousands, if not hundreds of thousands of lives saved. Similarly, we had projects underway in Alaska where the Alaska Native Health Center and what eventually became the NUCA system adopted improvements cumulatively so that they, by project work, change by change, they were able to come up with a team-based approach that would knock the socks off results. These are results that I got sent not long after NUCA started, where emergency utilization was going down, hospital admissions were going down, specialty utilization was going down because they were capacitating the primary care system. So these are results of intentional process changes in phase one. I would say that NUCA, the South Central Foundation, which really deserves study from all over the world, is a much more systemic approach today, but in those days they were improving stuff step by step. And it went global, thanks to Jason Leach and Derek Feely and leaders in Scotland, for example. There was a systemic adoption of project-based improvement that was remarkable. I think the first place that I believe was working at national scale, in this case on patient safety. This is a slide, I don't remember when Jason sent it to me, but not, it was, say, 2015, a 23% reduction in surgical mortality through a whole system of efforts in the entire nation of Scotland. I think the whole country was involved with this, a project focused on surgical safety and surgical outcomes. So we learned a ton. We really made progress as a community, and it turned global. This is work from Saudi Arabia, a hospital there working back on central venous line infections, and notice that the lower graph, it goes to zero. Months and months, if not years, of no central line infections. Harking back to Rick Shannon's leadership, Peter Pronavost's work in Michigan, we can go to zero, project by project. Stunning achievement. This raises some really interesting leadership questions, because if you know that hospital in Saudi Arabia can go to zero in central line infections, and let's say you're now in a hospital that has central line infections, the question is, who caused them? Who caused the central line infections? And my answer confrontatively is the Board of Trustees. If the governors of the place are not setting up a circumstance to take advantage of this knowledge and eliminate, or nearly eliminate, all central line infections, they're not doing their job. just as if they wouldn't be doing their job if there were a financial crisis that wasn't being met. So I think the game changed in a way as we became more confident about project-by-project improvement. The duty to improve, I think, came right into the heart of the organization. Today, I think it rests with boards of trustees and executives. Are we doing it? No, we're not. Still today, the kind of concentrated approach to case-by-case improvement, it's not widespread enough yet, even though there are 2,700 people in this room who absolutely know what I'm talking about. We have a job to do to settle the improvement work onto the desk, onto the agenda of every governance system in American healthcare, in world healthcare, because now we can save lives this way. We ought to look back on this with pride, celebrate it, and keep going project by project, but that's not enough. There was a new phase that began arriving. I don't know exactly when I'd say it began. Certainly, Maureen has had a key role here because when Maureen took over IHI, she helped reorient our work to a different sense of the role of communities and people. In the National Academy of Medicine committee that I was on, we said patient-centeredness. Not quite right. Not quite right. Now I think if we were to do it again, we might have the guts to do what should be done, which is patient control, person control, family control, community control, in which there's a shift of who's in the driver's seat. That's behind Maureen's teaching about what matters to you as the hallmark, which is spread globally. So that's a change, which is a new sense of the role of the person, the patient, the community in the guidance system for what we do. That wasn't in phase one, not that I remember. The boundaries have changed as we are taught by the Alaska Native Medical Center in Nuka and the South Central Foundation, by Yunshiping County. If you go there, you'll see it. By the country of Scotland, in that time, Derek and Jason were coaching a very willing Prime Minister, Nicola Sturgeon, to think outside the healthcare system to pursue health. And so the dimensions changed. Health without boundaries was a change. And that all implied a whole new understanding of systemness. Whole system quality was what IHI began talking about. It's alive and well today. If you take Josh Clark's work on care operating systems, it's that attempt to bring systemness into the picture. Now, as in most things, Tom Nolan knew this long ago. Tom, it saddens me in a way that you all, as generations pass now, Tom, who died, 4 years ago, Maureen? The single most important thinker for me in all of the improvement world, taught me more than any other human being. A decent, lovely, gentle man, whose work I hope you will study and learn and remember the name Tom Nolan, because he changed everything. Tom, along with another true giant intellect, John Whittington, in Peoria, Illinois, IHI faculty people, came to me in 2006 or so and said, you know that National Academy report, safe, effective, patient-centered, timely, efficient, equitable, that's not right. I mean, it's sort of right. That's all about the experience of people when they're in care. And we should do that. But why are they in care? Why did they break their arm? Why are they depressed? Why did they have a heart attack? The causal system does not lie in healthcare, and therefore the preventive system doesn't just lie in healthcare. We have to think totally differently about population health. So go ahead, get it right when they're in care, safe, effective, patient-centered, timely, efficient, equitable. But shouldn't we reach more broadly? And then, by the way, you're spending my money, would say Tom. It's all our money. And so every dollar healthcare spends is taken from something else. And that awareness puts a new burden on those of us who would seek improvement, which is the burden of cost reduction. So they centered that in the scheme, and they did it, Whittington and Nolan, by inventing this idea, triple aim: better care, better health, lower cost. All together. That's not a competitive scheme. That's a system of aims. And that was new thinking. Today, it's much more, we have new words for it, but I think that was a real challenge, a real breakthrough. what was going on here was a broadening of the idea of quality. The question I have, another alternative title for this talk, is how big is quality? And Nolan and Whittington and others enlarged it in many ways. One particular way that I want to go to is very personal, and I'm going to describe this to you. This person was my best friend for my life. We grew up in the same town. He's a little older than me, but we were never out of each other's company through our whole lives. Richard Bernstein. Richard was a magnificent journalist, head of the New York Times Berlin Bureau, head of the New York Times Paris Bureau, a book critic, an author himself. I think it's 16 books, some large number. You might look up his obituary, if you will, because he did die. He died this year. A tremendous loss, in my view. The story was this. Richard and I were together in last January, just after the Forum. I had never been to an opera, believe it or not. But I wanted to try, and Richard was an opera buff, so we got tickets together to the Metropolitan Opera in New York, and I went. I read up on La Boheme and Rigoletto, and oh my goodness, it was absolutely wonderful. A new part of my life. Richard was my guide, as he was for so many things, and he was fine. He was riding his bike every day and doing fine. And then came February, and I got a call from Richard that he was really in trouble. He was weak, he was having trouble walking, climbing stairs, very short of breath. And eventually, I called my friend Ross Wilson, who's an IHI faculty person in New York, where Richard lived, and he said, you could go to the emergency room. So Richard went to the emergency room. This is now late February 2025. And they did chest x-rays and eventually a CT scan. And the chest was fine. What wasn't fine was his liver. They caught the edge of his liver on a CT scan. He turned out to have widely metastatic pancreatic cancer. So that began a period of weeks when I was helping guide Richard into this system. Different speech, we could talk about that. But he did eventually get into good hands. Part of the journey involved a biopsy of his liver, and so he went for a biopsy on a Friday, and then we were speaking by phone afterwards. I said, Richard, how did it go? He said, it was fine, not painful, much simpler than I thought. He said, but I'm confused about something. When I asked them when I would get the report on my biopsy, the answer was in 5 business days. Let's put ourselves in Richard's shoes at that point. He's a smart guy. He knew he had a very, very serious illness. He knew that depending on his genotype and the morphology, there would be different possibilities of treatment and maybe prolonging life. He was waiting for the biopsy to tell him when he would die. And he asked, when would the result be ready? 5 business days. And Richard said, isn't there something wrong with that answer? I'm going to ask you to talk to each other for a second. I'll give you maybe 30 seconds. Turn to each other. And my question is, what's wrong with that answer? 5 business days. Okay, if I could bring you back to order, I'm not sorry again, not time, but I had a strong reaction. I tell you, my answer is everything is wrong with that answer. It's in layer after layer. And Richard, the journalist, Richard, my best friend, Richard, deeply feeling man, kind of knew it. Let's take the number 5 business days, 5 days. How if it were you were in charge and it was your kid and they were waiting for the biopsy result, we would follow what in the field of improvement is called the golden line. The golden line is exactly the value-added elapsed time, the minimum time in which you could get the right answer. What's the minimum time from surgery to the right answer in a liver biopsy? I don't know, I'm not a pathologist, but I will guess it's not days, it's probably hours. It might be 2 hours. So the number 5 is dead wrong when Richard, my best friend, is sitting there deciding, about to learn how long he would live. And then Richard says to me, business days, what is that? Why did they say 5 business days? What happened? What happened to us that word would get into the mix? This is a defect. It's a deeply seated defect. You can all understand the dynamics that might lead to that answer, but if you can look at that answer and say it's right, I disagree. This is abuse of my best friend by a system making a mistake. Of course, it's not the people. The person who spoke those words probably couldn't change the words. He or she is not in control of 5, not in control of business, not in control of anything. Who is responsible for giving my friend the right answer instead of the wrong one? Same people who are responsible for the central line infections. It's the board of trustees. It's the leadership of the organization that is setting in place the belief systems, the culture, the investments, the goals, the monitoring that would make this sentence go away. That's my opinion. You can differ, and I frankly would love to know if you differ. Now, I'm going to show you an alternative. Now, this, again, you will recognize from a forum speech of some years ago. Your job here is just sit, relax, and really enjoy this. That's a flash mob. Flash mob in Nuremberg, Germany, probably about 10 or 12 years ago. I've seen that 50 times, and every time I look at it, I just get a little choked up. There's something about that. What about that? What is so beautiful, if you feel as I do, about that coming together? That you have your own list. Here's mine. First, everyone helps. There's nobody irrelevant. Even the little kid that takes off his headphones and says, "Oh, I think I want to listen to this." The audience who joined the professional chorus to sing the Ode to Joy, everyone's in. And joy is a goal. Now, it's the Ode to Joy, so it's right on the surface, but this is about fun. This is about people coming together to do something that they badly, badly want to do, that they can enjoy. Now, it's not anarchy. It's not chaos. There is a unity, and it's a unifying score, Beethoven's score. The agreement is that we're going to follow the script together, Beethoven's script. Everyone can add what they want, but you play that script. And that's not by command. That's a voluntary joining in to get the job done that everybody really wants to done. This is a 6-minute video. For the first 3 minutes, there's no leader. All of that coordination and that music is coming without anybody in control. Then, if you saw a man, one of the violinists picks up a baton and starts becoming the leader because he wants to assert control? No, because to coordinate, there needs to be a conductor that is a servant leader helping everybody do what they want to do, but better together. It's not an authority, a servant to the purpose, a servant to the flash mob. And then something wonderful emerges, beautiful music, amazing genius, Beethoven. No one person could have done that. If any one person tried to do it, it'd spoil it. It's all together or not at all. And there is order, I say again, there's orderliness without command, without demand, and most importantly, without incentive. If we could just get rid of incentive, flash mob could do its work. The desire is to pursue a common aim, and every single person's expertise matters to the whole. What would it be like if healthcare was like that? Could that flash mob ever give my friend the answer in 5 business days? No. No, they're in a different space entirely, the space of purpose. What about healthcare? We can have a flash mob. I showed you this 2.5 years ago, 3 years ago. So it's a story some of you have heard before. This is my wife, Anne. We have our 50th anniversary in January. Well, we haven't gotten there yet, so just, love of my life, and we're so lucky to have met each other when we were 17 years old. Anne's an athlete. Her whole life, she's been out there skiing, swimming, whatever. She just wants to be active all the time. And she has been, despite a very serious illness that I spoke about in 1997 when she had a spinal cord disease that left her partially paralyzed. But that didn't stop her. Anne is still out there all the time, except 3 years ago when suddenly she couldn't walk across our living room. She was completely exhausted. And the story played out, but eventually we discovered the reason. The reason was that she had a destroyed tricuspid valve. For the clinicians in the room, she had a pacemaker in, and the pacemaker wire went through the tricuspid valve and destroyed the valve. Tricuspid valve is one of the 4 valves in the heart. Previously thought to be not that important. Ask Anne, it's important. So we searched the world for the best person we could find, and that turned out to be at Mass General, very experienced with tricuspid valve, a former Mayo Clinic surgeon named Dr. Tor Sunt. Dr. Sunt immediately agreed to operate on Anne, and so Anne had open heart surgery, a median sternotomy. As Anne puts it, that's not for wimps, a median sternotomy. It was very, very tough and very scary. For 10 days, we were, it felt like I was constantly teetering on the edge of a cliff. And the demands on Anne's body were beyond what I thought a human being could endure. Fluid balance challenges. She gained 30 kilos of fluid. heart arrhythmias, infection threats, kidney function threats, one after another through 10 days of intensive care. We were scared. I was disoriented, but they weren't. The team there knew what they were doing, and I'll describe that. But spoiler alert, the end of the story is that this is Anne on her e-trike, which she's put 7,000 miles on that bike. She's out every day she can, and in the snow, she's going to figure out how to run that in the snow. She's had that for years. She's fully recovered from a desperate situation. How? Flash mob. The number of different people that came together to save Anne's life and restore her to health, it must exceed 30 or 40 experts, not to mention all of the staff, including the cleaning people at night who gave her discussions about their grandchildren and hers that sustained her. Formally, the factors to me come from IHI's experience. Tom Nolan introduced us to a Aldrich-winning company called Sigma Aldrich Chemical Company in, I believe, Cincinnati. And we went to Sigma Aldrich to study them, and they were phenomenal. But they had 3 rules there. The whole management system centered around, they said, common systems, we'll agree to do this together. Common knowledge, what you know I know and can use, and what I know you can use. And unconditional teamwork. What is mine is yours, and what is yours is mine. It was infused into the organization. These have become my elevator speech about a world of improvement, about a flash mob. Common systems, we're gonna play the script together. Common knowledge, I will watch you play, you watch me play, will be coordinated. And unconditional teamwork. And the missing word there is with joy, with absolute spirit. It's what I benefit from every day, from getting to know and work with those blue shirts that have helped you too. There's total transparency. There are no secrets. Nobody hides. Everybody can see what's going on all the time. And the focus is on the purpose. Beethoven's score in the flash mob, and in the surgery, and on what matters to Anne. And they asked her, and they asked me. The technical skills were through the ceiling, but they were not concentrated in any individual, even Dr. Sunt. He knew that he needed to defer to the lowest level nurse or the new respiratory tech who might know something that he didn't know. We were lost, they weren't. And that sense of coming together, it is possible. The flash mob in healthcare is possible, but it's bigger than a project, which is my point. It's a phase 2 challenge. It's a different way to be. And it is totally focused on joy and comradeship and helping each other. And it's a transformation of the way we think and act. Too much in healthcare is affected by errors in our society, which has come to rely on finance and incentive and contingency and gold stars and dunce caps instead of, remember, the flash mob. That's phase 2. Phase 3, to me, is different. It is really broadening the bandwidth, really looking way outside the box, way outside the building for what it's going to take to give us healthy societies. That's a different enterprise from a well-run hospital or a flash mob surgery. It is a conceptually different enterprise to deal with the causes of ill health, climate change, inequity, patient safety threats, rapacious, confiscatory healthcare costs, and threats to population health. We call them simply social determinants of health. But if we're serious, we have to ask, well, what are these? Now, is this healthcare's problem? You can say, no, I'm a surgeon, I do surgery. I'm an orthopedist, I fix fractures. I'm a hospital, I treat the ill. Why should we get involved in collective action problems? Well, for the same reason everybody does, it's collective. Bystanders hurt. And healthcare has accrued to itself 20% of the gross domestic product and a tremendous amount of prestige and political power. If we don't get involved in change of the health-giving aspects of community, we're not doing our job. On the wall of the building that houses the National Academy of Sciences is a quote from Albert Einstein, who said, "The right to search for truth implies also a duty. One must not conceal any part of what one has recognized to be true." Follow the science, I would say. And I would say there's a right and duty for those of us that would improve the well-being of people. The right to improve and protect health implies also a duty. One must not conceal any part of what one has recognized to improve and protect health. So, what improves and protects health? Science does. It's an understanding of what the science is telling us has to be done in order to make us healthy. That does not include stopping immunization of infants for hepatitis B. That does not include walking away from the existential threat of climate change and saying, no, we're not going to play there. It includes attacking causes. The right to be healers implies a duty to honor the knowledge of healing. Now, we have a tremendous resource here. I've spoken about Sir Michael Marmot many times. He's my beacon. Michael is a world-famous epidemiologist, very, very gentle and lovely man, but spoken clearly about, in this case, his book is called The Health Gap. He's written much, and you should read it all, but The Health Gap you should buy. It was written in 2015, and he basically did a tremendous favor. He pulled together the literature on what it is that generates health. Why in my city of Boston is there a life expectancy difference geographically across the city of 20 years? In Flint, Michigan, it's 15 years. In Chicago, between the Loop and West Chicago, it's 16 years. Why these phenomenal gaps, not just among nations, not just among social strata, but even within cities, within towns? Michael's book basically tells us what creates health, at least in summary. This is my summary of it, 5 categories. What happens to kids, early childhood experiences, how our education systems function, especially for women and girls, but not only for everyone, not just for an elite few, what the workplace is like. So we have workplace conditions, including but not limited to minimum wages, that are good, and experience of elders, the way we deal with aging in society. And then a bunch of community resilience things, kind of Michael's miscellaneous chapter, food security, housing security, criminal justice reform, environmental threats, recreational opportunities. That's it. That's what if you want to be an investor in well-being, that's what you invest in. The United States is at the bottom of the list in every single variable among rich countries. Every one of them. Bottom. For the security we give our kids in early childhood. Bottom in terms of the evenness of our education. Our educational system is rated 5th in the world, but you go visit Holyoke, Massachusetts, and then take a breath, because we don't guarantee that to everyone. Workplace conditions. Our minimum wage is just at our poverty line. The experience of elders, we don't have elder care policy that's working well in this country, and community resilience, we just cut food stamps. We just took away housing vouchers. We just going through a period when it was already minimum. Michael asked the question, why do countries differ so, or regions differ so? And he has another chapter in his book. I think he uses the word fairness. It has to do with a social contract. It has to do with a flash mob. Do we want to play Beethoven's Ode to Joy or not? If not, we won't. But if we want to play health, we have to follow the rules. And that's a commitment to each other. And I have a treat for you. If this works, the technology works, I would like to introduce you to Sir Michael Marmot.
Good evening.
Good evening, Michael.
Good afternoon for California.
Michael is joining us at about 11 p.m. his time. He's in the UK. He just got back from Brussels, and I think he's been up for 24 continuous hours, but he agreed to join us. Michael, thank you so much. So I only have you for 4 or 5 minutes, Michael, but let's talk. Did I get it right? Am I summarizing your views of your understanding now about what creates health? What did I leave out?
You're doing it brilliantly. I've now got 8 principles, and I'll tell you in a moment how they came about. But pretty much building on what you said, my 8 principles: give every child the best start in life, education and lifelong learning. Number 3, employment and working conditions. Number 4 relates to what you said a moment ago. Everybody in a rich country should have the minimum income necessary for a healthy life. People should have enough to live on. Number 5, healthy and sustainable places and communities. And we've done a lot on housing of late. Number 6, taking a social determinants approach to prevention. So you don't just say, have a healthy lifestyle. You recognize the constraints on people's ability to do that. And then we've added 2, which should have been there all along: tackle racism, discrimination, and their outcomes, and pursue environmental sustainability and health equity together. So those have become the 8 Marmot principles.
Marmot principles. Now, okay, so that's brilliant academic work, great list, good words, wonderful book. Is anybody doing this? That is, what is your vision or your experience so far about what I will call, I don't think you use this term, Marmot places, Marmot cities? Can you tell us about that?
Yeah, if I could indulge myself for 60 seconds, just to give you the background, I chaired the World Health Organization Commission on Social Determinants of Health, and we made recommendations for 193 countries. It's a bit ambitious, really. So we made a virtue of necessity, and we said it was very important for countries to pick up our evidence-based recommendations and adapt them to their context. And Britain did. Gordon Brown, who was the Labour Prime Minister of the United Kingdom, invited me to conduct a review to answer the question, how could we apply the findings and recommendations of the Global Commission to one country, England? And I produced what became known as the Marmot Review. That was February 2010. The reason I remember the month is 2 months later, there was a general election and Labour lost the election. I'd like to think there was no causal connection between my report and Labour losing the election. But it's relevant because the Conservative-led coalition government that took over had no interest in following my recommendations. And in fact, much of what they did over the next 14 years was head off in the opposite direction. So the English city of Coventry said, if the national government won't do it, we'll do it. We'll take Marmot 6, as it was then, we've added the 2 I mentioned, and we'll apply them. The city government, the voluntary and community sector, the police, the fire and rescue service, business, health and care services, will apply them. And we'll put in place a monitoring system so we'll know if we're doing any good. I then went to Manchester, and the mayor of Greater Manchester had been the health secretary, the Minister for Health, when I delivered the Marmot Review, Andy Burnham. And I said, you know, Coventry, no one's really heard of Coventry. But if Greater Manchester did this, that would be really something. Andy Burnham said, we'll do it. So we did a report, they commissioned us to do a report, Build Back Fairer in Greater Manchester. And the city of Manchester picked it up. And based on my report, they produced a 5-year plan, making Manchester fairer. They invite me once a year to listen to the report of how they're doing. And again, they use the data to say, we're making progress here, we're not doing so well there. They listen to the lived experience of people of Manchester. So then I went to Liverpool and said, you know what they're doing in Manchester? So we got the mayor of Liverpool. Then I went to Newcastle and said, do you know what they're doing in Manchester and Liverpool? We now have 60 Marmot places in England, Wales, and Scotland. When we went to Manchester, I said, my wife has a request. Please don't call it Marmot. And they said, too late. It's a brand name. We talk about implementing Marmot.
Are there any in the U.S. that you know of, any Marmot places in the U.S. yet, Michael?
No, and I'd really like to do it. You know, the Republic of Ireland, Spain has contracted with us, Norway. Yeah, but there's a very big country that I've had quite a lot to do with over the years. I've lost count of how many times I visited, had a lot of contact. I did my PhD in Berkeley, so I've had a lot of contact, and we've got nowhere. And it relates, I've got a very complicated theory of change. If a door doesn't open, I don't bang my head against the door, I find a door that will open. And so if we can't get action at a national level, and your guess is better than mine, but I'm guessing we wouldn't get action at a national level in the United States.
Good guess.
Then we take action where we can. And my guess is there will be cities and regions who would be very keen to act on this kind of agenda. And my colleagues and I would be happy to work with them.
Did you hear that? My colleagues and I would be happy to work with them. So with Michael's kind permission, I'm issuing an invitation. If there are any cities, municipalities, regional areas that you are involved in and influential with, you have the world's expert on the causes of health, certainly a world's expert on it. I will act as an intermediary if you need it, but you probably don't. So I'd love to return to our forum in Phoenix in 2026 and celebrate the birthing of, how about a couple of dozen Marmot places in the United States under this kind of guidance.
That would be wonderful. And if I can just add one thing, you added a word. You were talking about three things, and you added a word, joy. It is real joy knowing that you're working with committed people who are striving every day against real odds. The cuts to local government funding from central government over 10 years were 59%. So if you say, does this cost a fortune? It doesn't cost a fortune because these local places have suffered brutal cuts. And they're absolutely committed.
Absolutely committed.
Absolutely committed. I come away, I went to East Suffolk. East Suffolk, I didn't even know the name of the railway station I had to get off. Why am I going to East Suffolk? I can tell you 150 local people turned out to the launch of East Suffolk as a Marmot place.
Thank you, Michael.
Real joy, absolute joy.
Thanks for your leadership, Michael, for your generosity, your willingness to be with us. And now it's time for you to get some rest, and we'll carry this banner forward.
My pleasure, thank you.
Michael wrote, inequities in power, money, and resources give rise to inequities in conditions of daily life, which in turn leads to inequities in health. This is phase 3. Think holistically. Think about the whole community. Think about everyone. And healthcare's potential leadership role in catalyzing the kind of work that Michael wants. Let's have 24 Marmot places, and we'll call them Marmot places whether he likes it or not. I've encouraged this in a prior speech with the 11 Teams Challenge, which you can look up in JAMA. This would be how a hospital can organize efforts to become a leader in the community around exactly the components that Michael Marmot and his research have nailed down for us. Now we have, by the way, technology to help. I have my latest toy picked up here in the exhibit hall. Is the it's called the what's it called? Pocket. Give me a minute. Pocket Talk. It's a little device. I happen to have learned now how to speak Swedish. I didn't know how to speak Swedish yesterday, but I do know now. So I really can speak Swedish, and I'm so proud of my achievement.
I really can speak Swedish and soft of nice.
I'd like all of Sweden to become a Marmot place.
Hi, it was Ika Carl Swind. We can't find a place like this.
Never play with technology, but I guarantee, Swedes are among my very favorite people.
Swedes and NYC, my very favorite people.
Oh, come on. That's because I had it translating from Swedish to Swedish. One more time. Now, Swedes are among my very favorite people. I love visiting Sweden.
Nu är svenskar bland mina absoluta favoritfolk. Jag älskar att besöka Sverige.
92 languages. I can also speak Sanskrit if you want. My point is technology is going to help us bridge into these new worlds of health and health giving, but not without phase 4. Phase 4 is the most uncomfortable, and it's where we are now but need to go whole hog, and that is political engagement. Quality is now become political. I think it was before the monstrosity of the current administration engaging in sickness policy, taking away supports that we oughtn't to be taking away. But we had a problem before that. We had the cost problem, the soaring costs of healthcare in America, the life expectancy lag. We're more than 4 years shorter life expectancy than the next richest country and then the median of OECD countries. We don't live as long. Our costs go up institution by institution. Hospital rate of I'll say confiscation of resources into the healthcare system is going up much faster than the cost of living or than wages, all for good intent. There aren't any really evildoers here. There are people trying to do well, but not looking at the system. It would be like a violinist and the flash mob had decided they play Chopin. No, it isn't going to work. Health insurance premiums are now through the ceiling. Vermont just passed Massachusetts at $50,000 a year for health premiums. 110 million people in our country have medical debt. There's no other country, no other developed country that would understand what that means. And we have 110 million people. The most frequent cause of bankruptcy and greed everywhere. The Medicare Advantage world full of confiscation of resources for no value added to the tune of $80 billion a year. We got a real problem here. And that was political policy, not partisan, political, before we ever got this problem in the White House. We were focusing too much on margin, too much on money. And the whole system has shifted now to a financial focus, really. Now, the justification by the good people doing that is, well, that's, no margin, no mission. I wish I could throw that phrase away forever and bury it. The theory of improvement, Deming, Duran, Ishikawa, Mizuno, Nariaki Kano, is very clear. If you work on quality, mission, if you get the flash mob playing the music, the money follows. If you don't believe that, it's really hard to play in the IHI sandbox. Deming called it adopt the new philosophy. The new philosophy is when every erg of energy is devoted to meeting the needs of the people you serve, the money will follow. We've got to remember, no healing, no mission, no equity, no mission, no sharing, no mission, no science, no mission, and return somehow to that. What are we doing instead? It's vicious. Cutting Medicaid now in this current bill, it's probably going to leave something. If everything happens as is currently being carried out, we're going to have about 17 million uninsured people, reversing almost all the gains of the Affordable Care Act. The cutbacks of CDC, the most envied, admired prevention organization in the world, now devastated, decimated, sad and bereft of the resources it needs to do its job. Cutbacks on NIH, so we're ceasing investment in research that matters. I spoke to Eric Topol last night after his speech. His research is being cut out of the NIH budget. He's going to have to struggle. USAID cutbacks, the worst of all. Millions and millions of people are going to die unnecessarily of HIV/AIDS around the country if we don't find a way to restore our country's proper generosity to the global south. Safety net cutbacks here. Medicaid, you heard at sessions here, just devastated. And the climate-related cutbacks. Remember, the WHO declared climate change the #1 threat to human health on the planet 5 years ago. And here we are bowing out. These are lethal policies. If a lethal germ, COVID, came into our midst, we in the improvement community would have to organize to say, no germ, stop it. And we're going to organize processes and investments so that germ is cut. The germ today is policies that are inhumane and murderous. And I personally believe that we have to stand up as a community and say no. We have the burden that Einstein talked about to make noise, not be silent in the presence of greed and attacks on science. We have to lead by example in our states, in our localities, in our organizations. And is it safe? No, it's not safe. This is a time of risk when you stand up for what is right, but we need to. We need to work with Congress to make sure they get a brain back, and we need to support the government institutions that are the places, the agencies like CDC that are our mission, and this can start in your organization. Is it our swim lane? Yeah. I simply follow the advice of Rudolf Virchow, the inventor of the field of pathology, one of the greatest biomedical scientists of the 19th century. Virchow was a fierce social advocate, and he wrote, medicine is a social science, and politics is nothing else but medicine on a large scale. The physicians, and he should have said nurses, he should have said all clinicians, are the natural attorneys of the poor, and social problems fall to a large extent within their jurisdiction. Phase 1 was projects. Phase 2 was systemic change and giving a different answer to my best friend. Phase 3 is listening to Michael Marmot. Phase 4 is saying no to policies that are harmful to the people we serve. Politics is nothing else but medicine on a large scale. Game on. We got to play that game. Thank you very much.
Thank you. Well, thank you, Don, for closing the forum only the way you can, with honesty, clarity, and hope. My name is Jill Duncan. I'm a vice president with the Institute for Healthcare Improvement, and on behalf of all of my colleagues at IHI, thank you. Thank you for being here. Thank you for thinking hard. Thank you for listening generously and for sharing your stories so openly. Before I let you go, and as you head to the doors, please do join me with one raucous, loud, enormous thank you for the blue shirts. Thank you. These are our IHI colleagues and our partners. They have carried the invisible work of the past 4 days that have made the forum possible, so thank you. So as we bring this forum to a close, I want to leave you with this final thought. Everything we've done for the past 4 days, the conversations, the connections, the shared purpose, it only matters if it travels home with you. So take it back to your teams, carry it into your next conversations, and let it change something small or something big and something real. And then come tell us about it, because we'll be waiting for you in Phoenix in 2026. Travel safely, stay curious, and continue to shape the care that the world deserves. Thank you, everybody.